This next question, let me start with Dr. Carter. And Dr. Carter, if you can think back to your residency, what's one thing that you've learned in practice that's totally different than what you experienced during residency?
I had about 20 things pop into my head just now, Michael. I think probably most pertinent is you can't help everyone, and we all want to. And it's really hard to have those tough cases where you may just not be able to feel like you've done enough. Maybe the meds don't work. Maybe the resources just aren't there. So I'd say probably the first thing is residency is a little bit sheltered, where a lot of times the cases are managed or are moved on to other things. And in real practice, sometimes you have to be that one person making the call on whether or not you can handle a case or not. It's really, really hard. It's really, really hard. I think another thing that I would say that I would learn is there's a lot you don't get taught. You are taught the basics. You're taught how to pass tests. You're taught how to manage, but there are going to be things that throw curveballs. The brain is a strange, wonderful organ, and there are some things that we just don't know. There's things we don't understand. And it's okay to recognize and admit when you don't know something. I think there's also this idea, and I think this is across the board for physicians, to be afraid to ask for help. If there's anything I have learned is to ask for help, whether it's with clinical or administrative roles, is don't be afraid to be vulnerable. Don't be afraid to have case consultations. Don't be afraid to throw ideas off of other folks. Sometimes that's frowned against. I don't know if that's a residency thing or someone who becomes a physician type thing, but don't be afraid to ask for help either. Don't be afraid to say I don't know and reach out. Probably a whole lot more, and I could go on and on, but those are some big ones. Is you can't help everyone, ask for help, and just recognize that sometimes just showing up is part of the job, and sometimes that's enough the validation and support that you can give someone, maybe all that you can do, and that's an okay thing still.
Thank you, Dr. Carter. Dr. Wakeham, same question for you. What's one thing that you've learned in practice that you really didn't think about during residency? It's totally different.
Yeah, for me, just given the way I progressed through my career thus far, it really was how to train others that weren't residents. So I was, I obviously was a resident and received training. Then I was chief resident and helped train. But for in my residency program, we didn't have at the time any APPs. We didn't have any nurse practitioners, any physician assistants. And it's a bit nebulous. Like different states have different regulations around what they can and cannot do. Do they need a supervising physician or not? And so what I wish, or what I've kind of seen change over the last 5 years specifically, is there's a lot of APPs that are kind of flooding into the psych market because of supply and demand and financial economics, and just supervising those individuals, I guess is a blanket statement. Educating them based on where they come out in their career, and then supervision of them, into their career and working side by side with you, is something that I had no idea about. Had to learn it as part of my own group practice, and now it's something we hold very valuable, is the ability to expand who we can touch with our care, without me or another physician having to do every single interview or every single direct patient engagement. So just that whole supervision structure, especially on an outpatient kind of group practice model, is something that I did not learn in residency that I wish I had, or that I know now, wish I knew then, wish I had some exposure to earlier in my career.
Thank you very much, Dr. Wakeham. Dr. Krugli, thinking back to your residency and maybe just some of the things that are so different in current practice to what may be a resident's experience in the last 5 years or 10 years, or just in general, what would you say are some of the great vast differences that you've learned?
Well, some of this might be artifact in the sense of when I trained, but I would say the biggest difference for me between what I learned in residency and what I have come to learn as a practitioner is the importance of interacting and working with families of patients. And I say this may be artifact, but in the 70s, and even in my first job at Bellevue, we never, or I shouldn't say never, but rarely did we include families in the patient's care or treatment plan, or whatever interventions we were going to make. It was kind of based on that individual model, that confidentiality model. You saw the patient, and nobody else was allowed to participate, or certainly nobody was invited to participate. And I would say in the last, as a geriatric psychiatrist, I invariably include family. I have to include families. I'm working with older patients who are not the most reliable historians. And I've actually gotten to a point before I closed my office, when I was still seeing office patients, I insisted that a family member come with the patient to the appointments because I didn't think the treatment could progress without a family member being present to make sure that the directions, the interactions were understood. I think going forward in psychiatry in general, the idea of seeing people one-on-one, well, yeah, it works in many cases, but I think the idea of including significant others and family members in the process, even if it's an office visit, I would say is something that should be seriously considered. I invariably, even now when I'm doing consults, whether it's in a nursing home or whether it's in the general hospital, I invariably, not every case, but probably 50% of the cases I see, I pick up the phone and I have to make a call to get the information I need to organize my thoughts and to do the right thing. So that's, I think, the most important difference between how I see things now and how I saw things during my residency and for the first few years afterwards, is being more inclusive of the patient's significant others and family members and so forth in the patient's overall care. That I think is a real difference for me.
Thank you, Dr. Krugli. Wonderful, wonderful words of wisdom from all three of you for our resident listeners.